Welcome to QuickShot 5, which is fetal basic science and clinical as well as neonatal. We're a little bit behind time, and so we're going to try to make up as much as we can before we get kicked out of the room. And so I think for the presenters, as folks are taking questions, if you can come up here, if you're the next person in line, so we can keep it going. 2 minutes for quick shot, 2 minutes for questions, and then as you're asking your question, please state your name and your institution where you're from, because we're recording for the journal from there. So, okay, all right. So we'll get started. The first one, Q57, is cord blood microRNAs as novel predictors of severity in congenital diaphragmatic hernia by Dr. Nguyen, UCSF.
Thank you for the opportunity to present. We have no disclosures. One of the current missing links in congenital diaphragmatic hernia is that often, they're advancing, often the prenatal anatomic factors don't directly correlate with the postnatal physiology and the postnatal outcomes. For example, with the commonly used lung-to-head ratio, there are times when you have a child that had a reassuringly high LHR of 1 or higher that postnatally develops pulmonary hypertension or worse. Our group was interested in finding out whether there are any circulating fetal biomarkers that could better reflect this change in physiology. We measured severity by the 2-week echo after birth. It's been shown that the degree of pulmonary hypertension at 2 weeks is strongly correlative with morbidity and mortality in the short term in CDH. And we define severe disease as having RV pressure over systemic pressure greater than 1. We then looked back at their cord blood, performed RNA sequencing in these groups as well as in term controls to see if there's a specific microRNA signature in severe cases. To review, microRNA are translational regulators. When they bind to the corresponding messenger, they can downregulate protein expression. In diseases such as preeclampsia, it's been shown that dysregulated microRNA in the placenta can shuttle over to maternal circulation and be non-invasively detected. We performed our study in 2 cohorts. And I'm presenting our discovery cohort. We found that 24 microRNA were differentially expressed and dysregulated in the severe group alone, as seen on the left side of the heat map. We're writing up these findings in a patent, so unfortunately I had to de-identify our findings, but we did see that several candidates were directly involved in the pathophysiology of this disease. For example, 2 were linked to VEGF, which is an angiogenesis regulator, and our colleagues in Canada actually found in tracheal fluid of fetuses that responded well to tracheal occlusion had higher levels of MIR200 and MIR10. And in our cohort, we actually found that one of these microRNAs was represented as well. We're now performing a validation cohort and looking at maternal serum, and our hope is that microRNA, in addition to biomarkers such as cytokines and prenatal atomic factors, could better create a model for prediction of pulmonary hypertension. Thank you.
Augusto Zani, Kids, Toronto. Very elegant study. Quick question about, you do cord blood.
Yes.
Did you have amniotic samples from amniocentesis? Because effectively we would like to know before these babies are born how severe they are, because so that we can actually intervene. And second question is about the stability of these microRNAs, which is very much being debated with regards to the preparation and handling of the blood samples. So that some researchers have been looking at circular RNAs or extracellular vesicles.
Yes, thank you. That's a very good question about the amniotic fluid. Thank you. We have colleagues that are looking at NMR spectroscopy in amniotic fluid as a surrogate biomarker. For our samples, unfortunately, we did not have amniotic fluid. Many of these patients were referred to us for birth, and so we have cord blood collected at birth only in addition to maternal blood, but that's definitely something to look at because those other teams have found specific signatures using NMR as well. In regards to your second question, also excellent, thank you. We standardized our collection procedure over 12 years. Basically, as soon as we get the cord blood on the same day, we spin it down and put the serum to -80. And then on the first thaw, we send it for sequencing. So we tried to account for that error as much as possible by reducing freeze thaw effect. In terms of the stability of microRNA, you're right. It would be better to discern whether this is an effect of free circulating microRNA or those that are in exosomes from cells. And that is a step that we should take in the future that we have not yet. Thank you. Thank you.
Thank you.
Thanks.
Right. Next presentation is Q58, delayed Eggman Cannulation in patients with congenital diaphragmatic hernia. Is it safe to leave cannulas in place? Presented by Dr. Pilkington.
Thank you for the opportunity to present. We have no disclosures. Our current practice is to cut away patients from the ECMO circuit once they have passed a clamp trial off of VA ECMO. The neck cannula are left in place with a heparin infusion running for approximately 24 hours. This gives us a prolonged period of observation during which we can ensure readiness for decannulation, hopefully avoiding any risky second recannulations. But we sought to clarify whether this was helpful or harmful in our patients with CDH. We performed a retrospective review of our patients with CDH who were electively decannulated from ECMO. After excluding those with VV cannulation, as well as those who were either palliatively or decannulated in an unplanned fashion, we were left with a cohort of 19 patients. After a median ECMO run of 10.7 days, our patients were cut away for a median of 26 hours with a range of 1 to 65 hours. Only one patient was ultimately reconnected to the ECMO circuit during the period of being cut away. She'd been cut away for 36 hours and ultimately required an additional 55 hours of ECMO support. During the period of cut away, there were no deaths, bleeding events, or embolic events in our patients. 2 patients were ultimately offered a second recannulation after 3 and 16 days. The first patient was ultimately palliated, and the second did undergo recannulation in an open fashion by the cardiac surgical service. So in summary, we showed that the procedure was safe to leave our patients cut away from the ECMO circuit. And while conceivably all of our patients benefited from this prolonged period of observation, only one patient directly benefited from utilizing the indwelling cannula to reconnect to the ECMO circuit. That said, if the number needed to treat truly is 19 to prevent a risky second recannulation, then perhaps this still could be considered a benefit to all. Larger studies are needed to validate our findings here and to determine what the optimal length of time is and who stands to benefit most from this procedure. Thank you, and I'm happy to take any questions.
Jason Fisher, NYU. It's really great work. We actually got in a pretty heated discussion with our cardiac team about whether this was safe to do or not, and so it's nice to see that apparently is. Just a quick technical question: with you leave a heparin infusion going, what sort of dose and rate? I mean, is this I'm assuming not fully anticoagulating them, or is it just like a nominal sort of low
It's
dose
a
infusion?
nominal prophylactic dose. Thanks for the question. We run our heparin at 2 mils per hour in both the venous and the arterial, and we do not routinely monitor any anticoagulation status during that time, as it's purely prophylactic.
Rusty Jennings from Boston Children's Hospital Esophageal and Airway Treatment Center. I have a question. The central cannulation for ECMO, I think that's something that pediatric surgeons are able to do. I don't think that you have to need to necessarily call a cardiac surgeon just because you need to do a central cannulation. And maybe that's a simple skill to acquire. We do it literally all the time, once a week for the last month or so. So I would just raise the option of pediatric surgeons acquiring the skills to do a central ECMO cannulation as a safe alternative to peripheral cannulation.
Yeah, thanks for your comment. Absolutely valid.
I have a quick question. On the abstract, it says that when you took the cannulas out, 4 of those had clots. Mm-hmm. So how, in the patient that you reconnected to ECMO, how did you know that there was no clot in the cannula, around the cannula? Did you do an echo or any type of study to know that there was not a clot as soon as you connect the arterial pump, it just goes?
So we didn't do any formal study at the time of the reconnection, to my knowledge. One was done, I believe, shortly thereafter, but really for other reasons. The clots that we described were those that were actually visually seen within the cannula, and none of them were obstructing or blocking the heparin flow, but they were visualized, and so they were manually removed prophylactically. So you're right, there's no guarantee that those weren't present in the part of the cannula that wasn't visible, but ultimately we didn't see complications from those in our other patients, but it is a potential risk, and that's why, even though we showed it to be safe in our cohort, we recognize this is a small group and complications are likely to be rare, and so it really needs to be looked at in a bigger population to truly say this is safe for everyone.
Thank you.
Next presentation is QuickShot 59, low postnatal compensatory reserve index values are associated with the need for ECMO in newborn with a CDH. Dr. Phillips from Colorado.
Thank you for the ability to present our work today. Doctors Mulligan and Moulton have ownership and board of directors of the technology discussed today as disclosures. The research was supported by grants from the U.S. Army, the NIH, and the Department of Defense. None of the other authors have anything to disclose. So predicting which diaphragms will require ECMO remains challenging. The compensatory reserve index was developed for machine learning algorithms based on the pulse ox waveform, and it ranges from values of 1 to 0, with 0 being decompensation. It's the first FDA-cleared adjunctive cardiovascular status indicator. It trends real-time changes in intravascular volume. So we hypothesized that postnatal CRI values would be lower in newborns with CDH compared to that required ECMO. It's a single-center prospective study. We enrolled 26 neonates. We enrolled them within the first 24 hours of life. If they went on ECMO within the first hour of life, they were excluded from the study. So the basic demographics between the group were the same, other than the fact that we had 2 right CDHs that went on to ECMO. When we looked at lung-to-head ratio, there was no difference between those that went on ECMO versus those that not. The total lung volume in ppLV, there was no difference between the two groups. I mean, there was a statistical difference between the two groups, and the average CRI value was significantly lower in those that went on to ECMO. When we look at the box plot between those that went on ECMO versus those that didn't, you see there was a larger number of CRI values for those that did not go on ECMO compared to those that did. And we looked at the area under the curve. Those that had the lowest CRI had the highest sensitivity and specificity with an area under the curve of 0.85, which was better than ppLV, which had an area under the curve of 0.84, and O to E, lung-to-head ratio, which had an area under the curve of 0.69. So humans share a fundamental feature of the pulsatile waveform that can predict decompensation, and CRI might aid an earlier decision to initiate ECMO, and further studies are needed to be done to see if CRI can improve long-term morbidity and mortality. Thank you for letting me present my work today.
Hi, Matt Harding, University of Texas in Houston. Very nicely presented, interesting work. Be great to be able to predict this earlier. My question is, why do you think this is the case? Right, certainly there's emerging evidence that left ventricular dysfunction plays a much larger role than we thought previously. But I'm interested, did you correlate this with echocardiography? Did you correlate it with what your fluid resuscitation status was? It seems like there's a lot of factors that might play into this. Again, thank you.
Sure. Thank you for the question. It's a great question. We have not actually done that yet, but we're in the process of doing that because we agree that that's an important thing to look at.
Stan Adkins, Columbia, South Carolina. Were you guys blinded to the CRI when you were making the decisions to go on ECMO?
Yes, we were.
Yeah, it's sort of, it's Jack Langer from Toronto. As a person who comes from a place that hardly ever uses ECMO and still has the same kind of survivals that the ECMO centers do, the term requires ECMO is a relative term. You're really saying is those are the patients that you chose to put on ECMO based on clinical criteria. So you're now correlating that with another measurement, which really just echoes the decision-making that you made based on the other stuff. So I'm not sure how it's actually going to help you. You're still going to put those patients on ECMO based on the clinical criteria that you chose in the first place.
Yeah, thank you for your comments and questions. I think the main thing with that is that it would help potentially get you on earlier before the labs change, because we've seen the labs change after the CRI values. So,
thank you.
Thank you.
Thank you. Okay. The next talk is number 60, the surgical management of gastroesophageal reflux disease in patients with congenital diaphragmatic hernia. Synchronous LAD surgery may be protective. This is Dr. Laje is going to present for Dr. Baumgartner.
Yeah, so sorry about that. The first author had to fly back home last night emergently and asked me to present. So I wasn't part of the study, but I work there, so I know what they are talking about, I think.
Get your questions ready.
Yeah, I won't answer anything. I don't necessarily agree with what they say, but that's okay. So patients with CDH have a number of issues like delayed gastric emptying, impaired lower esophageal sphincter, dysfunctional chest mechanics, an incompetent hiatus, and also a rotational anomaly that could lead to reflux and feeding intolerance, whatever the definition is. And virtually all patients with CDH are placed on anti-acid medication. But in some cases, the severity is such that it presents the potential need for an intervention. So what the team did was look back, did a retrospective study or review between 2000 and 2017 about what was done for reflux and feeding intolerance. There was no protocol, no standardization of what should be done at what time, when, and for what. All cases were just done based on surgeon's preference. So they just looked at what was done for each baby and what happened with the baby. So basically there were 472 CDH patients, 159 were excluded for death or fetal. 313 were included in the study. 213 did not undergo any surgery, and 100 patients did undergo some type of surgery. It could be a LAS procedure in 49 cases, most of which were done at the time of the CDH repair. 39 patients underwent a fundoplication, and 12 patients underwent both. So this is what they found. Basically, they compare the two groups, no surgery, LAS surgery, mostly at the time of CDH repair, and then Nissen and both. And the interesting findings of the review were this. So mostly they compare patients with no surgery whatsoever versus patients who underwent a LATS or some form of LATS or correction of the rotational anomaly at the time of the CDH repair. And they found that the age at which the patient started enteral feedings, the age at which they reached full feedings, and the percentage of patients that went home with no tube feedings, just exclusively on oral feedings, and the hospital stay was better for those patients who had undergone some type of repair of the rotational anomaly at the time of the CDH repair compared to patients who underwent no surgery. So their perception, not a conclusion, but their perception is that patients who undergo these LAS procedures at the time of the CDH repair do a little bit better than if they don't. They also perceive that the gastric outlet should be at least looked into at the time of the CDH repair, but also if you're committed to do a Nissen fundoplication on a CDH patient, it's important to look at the gastric outlet and try to distinguish if that's also an issue that needs to be addressed. Thank you.
Any questions for the non-author? Author?
I can take it. Go for it.
Yeah.
There you go.
Not really processing all of it, but just thinking, like, have you thought of any potential confounders there? And also, how much did that lengthen the time of the original procedure? Were there some that didn't get a LADS because they were more comorbid than the ones that had time to and the luxury to be able to do a LADS at the time?
Absolutely. I think, the question is complex, and the answer is more complex. And in discussing with Dr. Blidman, who was the senior author, the one thing that is important to say here is that this is a very murky territory. CDH itself is so heterogeneous, the severity varies enormously, and there are so many comorbidities and things that would determine your outcome that interact with each other that it's impossible to conclude that one little simple thing is going to make you better in every way. So, I don't have any detailed thing to show you, but it's a great question.
Decopi London, thank you, Pablo, for sharing this interesting data. I don't know if you do thoracoscopic repair CDH. Would you advocate them looking and eventually doing a LADS on this patient or not?
So the ones that are done minimally invasive, at least in our hospital, are not many. The vast majority of the ones that we get are very sick and just undergo laparotomy. And the ones that we do minimally invasive are usually done through the chest. So I'm not sure, obviously you couldn't do the anomaly correction, the rotation correction through the chest, but if you did it laparoscopically, I think it's something that if you have time and the patient is stable enough, you could look into. But,
thank you.
You're welcome. All right, thanks.
You want to introduce the next one? Go for it. All right, our next presentation is amniotic fluid stem cells exosomes promote fetal lung maturation in an in vivo model of congenital diaphragmatic hernia by Dr. Montalva from Sao Paulo.
Thank you. Chairpersons, ladies and gentlemen. We have recently reported that amniotic fluid stem cell exosomes hold a great regenerative potential in several disease models, including lung damage. In search for a new treatment for pulmonary hyperplasia secondary to CDH, our lab has been studying the ability of AFSC exosomes to promote lung regeneration. Using the nitrofen model of CDH, we have previously shown that AFSC exosomes promote growth and maturation in fetal lung explants, primary epithelial cells, and fetal lung organoids. More recently, we found that AFSC exosomes could also promote alveolization in vivo in a surgical model of CDH. So the aim of the present study was to investigate the molecular pathways that AFSC exosome treatment activates in the hypoplastic lung. AFSCs were isolated from rat fetuses by positive c-KIT selection. We collected conditioned medium and used ultracentrifugation to pellet the exosomes. Exosomes were then characterized for morphology, size, and expression of canonical protein markers. To test the effect of AFSC exosomes in vivo, we used the rabbit model of CDH, whereby a left diaphragmatic defect is created surgically. Two groups of fetuses then received the treatment, either by tracheal occlusion alone or by tracheal occlusion with intratracheal administration of AFSC exosomes. At term, the left lung was harvested and analyzed for targeted gene expression. We investigated the main pathways involved in alveolization, and we found that the one activated by AFSC exosome treatment was BMP. BMP plays a crucial role in lung development by guiding branching morphogenesis and distal lung differentiation. In fact, we found that the expression of ID1, a downstream target of BMP, was decreased in the lungs of CDH fetuses compared to control. It was not increased by tracheal occlusion alone, but it was restored back to control levels by AFSC exosomes. Moreover, we found that the expression of two BMP ligands, BMP2 and BMP4, was increased upon administration of AFSC exosomes. So in conclusion, we found that AFSC exosomes promote fetal lung maturation by activating BMP. We believe that this stem cell-derived therapy is a promising novel approach for babies with CDH. Thank you for your attention.
Good morning. Lovely presentation and very innovative work. My only question would be, you've done targeted sequencing. Will you do can you do whole or full RNA sequencing or single, as you would for single cell?
Thank you for your question. So we did initially do RNA sequencing, but we had some trouble with technical problems in our institution, and we did not have enough reads to actually have significant results. So we did qPCR for every factor that after doing a literature review, I found all the factors that had been previously reported as involved in alveolization, and I tested by qPCR every factor mostly.
I think that it's lovely work, but I would certainly recommend going forward to full sequencing.
We are currently doing more investigations, and we are going to repeat RNA sequencing. Thank you.
Hi, good morning. Todd Jensen from Connecticut Children's. Really great work. Have you identified what in the exosomes is actually causing the modulation in BMP signaling? Is it miRNA based? Is it protein based?
Yes, so in the interest of time, I didn't expand more on this, but we have recently published actually an article discussing potential effects of AFSC exosomes, and we do believe that microRNA hold a big role in this.
Thank you.
Dario Fauza, Boston. Interesting work. When tracheal occlusion is performed combined with the delivery of liquid into the lung, you can have very different results from tracheal occlusion alone. So shouldn't you have a control group with the tracheal occlusion plus the infusion of whatever you use to suspend the exosomes in a volume-matched fashion?
Yes, so we have a control group, which I did not show in this work, with injection of saline only compared to exosomes. And there's no difference. It's the same difference as tracheal occlusion alone. Thank you.
Thank you. At this point in the session, we're going to take a break and proceed with the tribute for this session, which is dedicated to Dr. Fred Arcari from Detroit. He was an organizing original member of APSA. This presentation was developed and created by Pablo Laje from the Children's Hospital of Philadelphia.
Can you play, please? Got it. So Dr. Arcari was the son of a Italian father and a Scottish mother. He was born and raised in Scotland, went to med school in Glasgow, and served as a physician in the British Army. And he afterwards came to the States and developed a reputation as a true gentleman. He trained in pediatric surgery with Dr. Lynn in Louisville, Kentucky, way before formal training was in effect. He was appointed pediatric surgeon at Children's Hospital of Michigan. That was his first job, and a few years later he moved his practice to Beaumont Hospital, not far from Children's Hospital. And eventually he achieved his certification, and he was awarded the certificate of a pediatric surgeon by the American Board of Surgery, and that certificate was number 16. And that certificate now is in the office of one of his trainees and former colleague, Dr. Morden. Dr. Arcari was a superb surgeon, according to his former partners, very astute, and he had a big interest in neonatal surgery. He was a strong believer in operating on TEFs emergently, and actually not operating on biliary atresia babies at all, which, in that time was probably the most common belief. He eventually traded his clinical practice for a career in administration, but even then he was a down-to-earth person. He was certainly a part of the development of APSA, and he's a founding member, as we can see here in our website. And he was also a founding member of the Lilliputian Society, which is a group of selected pediatric surgeons that persists until today. He was married to Dorothy. They had 6 kids. He was an avid sailor. He loved the outdoors. After he retired, his daily activities were mainly reading and drinking whiskey. He was certainly a founder of ped surgery in the United States.
Go for it. Okay. All right, our next presentation is predict the need or benefit of descending aortopexy in addition to posterior tracheopexy for the surgical treatment of tracheobronchomalacia by Dr. Svitnov.
Good morning, and thank you for the opportunity to present. One component of tracheomalacia includes posterior intrusion of the trachea and left mainstem bronchus during exhalation. To relieve this compression, stabilization of the posterior membrane to the anterior spinal ligament can be performed. For left mainstem disease, the aorta may need to be moved to fully relieve this compression. Our aim was to identify preoperative variables that would predict the need of performing a descending aortopexy. This was a retrospective analysis from 2012 to 2017, with the conventional cohort including patients who underwent a posterior tracheopexy alone, and the interventional cohort including patients who underwent a posterior tracheopexy and a descending aortopexy. The preoperative workup included a dynamic 3-phase tracheobronchoscopy and a CT scan to look for great vessel anomalies and to measure the percentage of the aortic diameter located anterior to the spine, termed the aortic spine border measurement, as you can see in the picture on the left side. With a descending aortopexy, the aorta is repositioned to be in line with the spine in order to fully relieve the mainstem compression. Looking at demographic variables, patients with a history of esophageal atresia were associated with not performing a descending aortopexy, while there was a significantly higher percentage of patients who underwent a descending aortopexy that also had great vessel anomalies. Less than 25% of the aortic diameter located in front of the spine was associated with not performing a descending aortopexy, while greater than 50% of the left mainstem bronchial compression was associated with the performance of a descending aortopexy. On multivariate analysis, left mainstem bronchial compression was the most significant predictor of performing a descending aortopexy. In conclusion, patients with greater than 50% left mainstem compression and or greater than 50% of the aortic diameter located anterior to the spine should be considered for a descending aortopexy at the time of surgery for tracheobronchial malacia. Thank you, and I'd be happy to answer any questions.
I might have missed it in the data, but was there a strong correlation with left main bronchial? Could you say and or as part of the conclusion?
Yes, so the most significant predictor, both in the univariate analysis and then here on the multivariate analysis, was greater than 50% left mainstem compression, as seen on the preoperative bronchoscopy.
Okay, thank you.
Thank you.
Next presentation is Q63, effect of intraoperative temperatures on postoperative infections in infants, presented by Dr. Amin.
Good morning. Thank you for the privilege of presenting our work. We have no relevant disclosures. Perioperative temperature regulation has been shown to impact surgical morbidity in the adult population. However, its effects on infants and neonates remains largely unknown. This becomes important as this population is at greater risk for temperature instability, both due to their immature thermoregulatory mechanisms as well as an increased surface to volume exposure ratio. With this study, we sought to identify if intraoperative hypothermia was associated with SSI development within 30 days of surgery. We performed a retrospective study of patients less than 6 months of age undergoing abdominal and thoracic procedures at a level 1 children's surgery center. Our primary outcome measure was the development of infection within 30 days of surgery, with particular attention to the development of surgical site infections. Data obtained included the weight and age at surgery, wound and ASA class, case length, the need for perioperative blood transfusion within 72 hours of surgery, and the administration of prophylactic antibiotics. In the 885 patients studied, we had 25 that went on to develop a surgical site infection and 11 that developed a non-surgical site infection. On bivariate analysis, we found that a lower weight, a higher ASA class, the need for transfusion, longer case length, and hyperthermia at any point during the case was associated with the development of surgical site infection. On multivariable regression, we found that hyperthermia at any point during the case and the need for perioperative transfusion within 72 hours of surgery was also associated with a higher rate of SSI. In this study of 885 patients, we did not find an association between intraoperative hypothermia and the development of SSI. However, we did find that intraoperative hyperthermia and the need for perioperative blood transfusion was associated with the development of surgical site infection within 30 days of surgery. Further studies are needed to validate the negative effects of these potentially modifiable factors. Thank you, and I'd be happy to take any questions.
I have a question. Maybe this one is a little impossible, but could you elaborate or did you think of what would be the mechanistics behind the finding?
Sure. One of the considerations that we had discussed when we were doing the study is that maybe they had pre-existing infection that just manifested in the perioperative period. And so we did go back and take a look at the patients that developed an SSI. However, given that it was retrospective, it was difficult to delineate what exactly the causality would be. For example, we had 6 patients that had intra-abdominal sepsis, 3 of which were hypothermic during their case, 3 of which were hyperthermic during their case, and only 1 went on to develop an SSI. So I think it's difficult in this sense to really say what caused that, and we weren't able to find that, but I think as we continue to collect more patients and look at this maybe in a more prospective manner, we may be able to find out.
Thank you.
Doug Miniati from Permanente Medicine in Northern California. Thanks, a very nice presentation. One of the things that you bump up against when we're trying to get the temp up in our rooms for our neonates is the humidity factor. As the temperature goes up, you start to lose humidity. You think that might have played a role?
I think that's definitely something to consider.
Thank you.
Thank you.
Our next presentation is in utero treatment of meningocele with placental mesenchymal stromal cells, rescue ambulation on the ovine model, selection of an optimal cell line.
Thank you. Fetal repair of myelomeningocele has decreased rates of ventriculoperitoneal shunts. However, the majority of children are still unable to walk. We have previously shown that application of early gestation human placental mesenchymal stromal cells at the time of myelomeningocele repair results in ambulation in a sheep model. The next step in preparation for clinical trials was to develop an in vitro assay to screen our future placental cell banks. We compared cell lines from 3 different placental donors. First, we performed an in vitro neuroprotection assay that determined how well the 3 different cell lines could rescue apoptotic cells when placed in indirect co-culture. Next, in our animal model, the same 3 cell lines were used to augment the fetal repair, and motor function was tested following birth. Finally, we measured motor neuron density and the spinal cord gray matter. The in vitro neuroprotection assay, line A and line B, shown in green, had significantly higher neuroprotection compared to no cells, which is shown in black. Similarly, line A and line B, again shown in green, had significantly higher motor neuron density in our sheep than no cells. But in neither assay did line C, in red, perform better than no cells. In vivo, all 3 cell lines were able to rescue ambulation in our sheep. There was no statistical difference in motor function among these 3 cell lines. However, we did find a strong positive correlation between motor neuron density on the vertical axis and motor function score on the horizontal axis, strongly suggesting that the mechanism of action is through preservation of motor neurons. In conclusion, fetal repair of myelomeningocele with placental mesenchymal stem cells results in ambulation regardless of the cell line used. The in vitro neuroprotection assay corresponds to our in vivo motor neuron preservation. Therefore, we'll be using the neuroprotection assay to screen donors and select the ideal cell line for use in our upcoming clinical trials. Thank you.
Augusto Zani, Toronto. It's very elegant study. It's really beautiful, and congratulations for going into a clinical trial. My question is about the engraftment rate of these of the MSCs. Do you see a lot, or do you see just a little, and you think that this is a paracrine mechanism to work with?
Thank you. In all of our studies of immunohistochemistry to take a look for engraftment, we have never seen any persistence of the cells after birth. So we believe that the mechanism of action is indeed, like you said, paracrine in origin from secretion of cytokines from a variety of different types.
And so my next question is, have you thought of using the secretome from these cell lines rather than the cells themselves with all the advantages of a cell-free therapy?
Absolutely. We have another number of projects in the lab looking at exosomes to try and characterize what is being secreted and can we deliver that in a cell-free manner. Thank you very much.
Well done. Exciting.
I might have missed this because of these quick shots. If you blink your eye, it's you miss half the presentation. Can you put the stem cells or whatever cellular components in it could still be the same the secreted products? Can you put them in a matrix on the patch? It always bothered me that you would use the patch and not add some component to this.
Absolutely, thank you. Due to the time, I didn't explain that the delivery method for these stem cells is that they are seated on an extracellular matrix, which is the same dural graft that we used for fetal repair. So just like in the mom's trial, those patients that required a dural graft, it's essentially adding the stem cells to that
Thank you very
therapy.
much. I guess I didn't miss it.
Thank you.
Thank you.
In the interest of trying to stay on time, we'll try to limit to one question after each presentation from now. Next presentation is repeat dosing of retinoic acid model of transamniotic stem cell therapy for spina bifida by Dr. Tracy.
Thank you for this opportunity. In previous experiments, we found that mesenchymal stem cells present in amniotic fluid contribute to fetal tissue repair. This led to the development of transamniotic stem cell therapy, or TRACE-IT, where high concentrations of these cells are injected into the amniotic cavity to boost their role in the setting of diseases such as spina bifida. When TRACE-IT was applied in both rat and rabbit models of spina bifida, we witnessed enhanced rates of either partial or complete defect coverage by a rudimentary host-derived skin. Interestingly, donor cells were not found in this neoskin, but at sites reachable through the bloodstream, particularly the fetal bone marrow. In this study, we sought to assess the fetal response to single versus repeat dosing regimens in an effort to better understand how TRACE-IT works. Fetal rats with retinoic acid-induced spina bifida were divided into 3 groups. One group was left untreated, and 2 groups underwent TRACE-IT at either 1 or 2 time points. Syngeneic donor cells were phenotyped by flow cytometry and labeled with GFP. Animals were euthanized at term for various analyses. Repeat injection was associated with a significant reduction in fetal survival. We found no significant differences in defect size among the 3 groups when controlling for fetal dorsum surface area. The single injection group had a significantly higher rate of histologically confirmed defect coverage, whether partial or complete, compared with the untreated and repeat injection groups. Donor cells were seen in fetal bone in both treatment groups, but once again, not in neoskin. In conclusion, despite the limitation of the short rat gestation, these findings suggest that the effects of TRACE-IT may not be dose-dependent. Given the presence of donor cells in fetal bone marrow, as documented by our previous work, these effects may derive from a lasting host response, possibly based on bone marrow activity. Further investigation into such a response could lead to additional non-surgical strategies for the prenatal coverage of spina bifida, and perhaps even cell-free therapies. Thank you.
Hi, I'm Joe Davidson from London. Did you have any insight into why your fetal loss was so high in the repeated doses? Were you looking at the fetal autopsy at all, or were they cannibalizing the babies, as often happens with ours?
That's a great question. We actually sacrificed these moms and babies before delivery, so cannibalism wasn't part of the fetal loss. We suspected that the earlier injection time point combined with a later injection time point was just a very aggressive treatment regimen, and 2 open laparotomies on the moms was a lot.
Thank you. Next presentation, a comparison between placental and amniotic mesenchymal stem cells in transamniotic stem cell therapy for experimental gastroschisis, presented by Dr. Chalpin.
Good morning. Thank you for the opportunity to present our work. We have no disclosures. As my colleague just described, transamniotic stem cell therapy, or TRACE-IT, has shown promise experimentally in the prenatal treatment of congenital malformations. In abdominal wall defects, we have previously demonstrated that TRACE-IT with mesenchymal stem cells, or MSCs, derived from the amniotic fluid, mitigates bowel damage in both rat and rabbit models. However, it remains unclear if MSCs from other sources possess the same therapeutic potential. In this study, we sought to compare MSCs derived from the placenta, PMSCs, and amniotic fluid, AFMSCs, in TRACE-IT for gastroschisis. Using the surgical rat model of fetal gastroschisis, fetuses were divided into 4 groups. Group 1 received no further intervention. Groups 2, 3, and 4 received volume-matched intraamniotic injections of either saline, AFMSCs, or PMSCs. All cells were syngeneic, phenotyped by flow cytometry, and labeled with a GFP reporter gene. Herniated bowel was procured at term for histologic analysis, including GFP immunohistochemistry and computerized measurements of all 3 bowel layers. We found that both cell treatment groups led to significantly thinner segmental and overall bowel wall thickness compared to controls, with the AFMSC group outperforming the PMSC group.
Furthermore, Levine's test demonstrated heterogeneity of variance between the groups, with the AFMSC group producing less variability. Labeled donor cells were identified sparsely and in clusters in both the serosa and mucosal epithelium. In conclusion, both placental and amniotic mesenchymal stem cells mitigate bowel damage in transamniotic stem cell therapy for gastroschisis. However, amniotic cells produce improved and more consistent results. These findings support the perspective that TRACE-IT may become a realistic alternative in the prenatal management of gastroschisis. I'd like to thank my mentors and co-authors, and I'm happy to take any questions. Thank you.
Congratulations on nice iterative work that your laboratory is doing. I'm just curious about the thought process behind the rationale for the study. You know, your lab has already demonstrated the usefulness of amniotic fluid stem cells. What's the disadvantage that you're trying to overcome by looking at the placental?
Sure, thank you for the question. There's a couple thoughts. One is the amniotic fluid is a great source for cells, easy to obtain. You can actually obtain placental mesenchymal stem cells slightly earlier, and so that might be one advantage. While amniotic fluids and dosing in rats and rabbits has worked well, in humans, if it becomes clear that you need to procure these cells earlier, that's one option.
Do you think that in the clinical application, obtaining amniotic fluid cells from fetuses affected by gastroschisis might perform less well?
That's another great question. There's no direct evidence that I'm aware of, and we've sort of looked at this, but that certainly is a possibility. And as we go forward and hopefully soon try do this in clinical trials, that's something we're going to absolutely be keeping in mind. TRACE-IT is a really one of the powers of this approach as well. We sort of envision it as being an autologous process. It does have the ability, you can source these cells from other individuals. So if that becomes clear as we move forward, that's also a possibility.
Thank you.
Thanks.
That last question was from Doug Miniotti from Roseville, California. Our next talk is development of a uterine tone monitoring device for fetal surgery by Dr. Al-Jabouri.
Good morning. The premise of fetal intervention rests on accurate monitoring and control of uterine contractions. Currently, the uterine tone assessment is achieved by manual palpation and visual inspection of uterine tone, which is prone to misestimation. Therefore, a direct objective method to measure to control and measure quantitatively the uterine tone is needed. We developed Urotech device, and we've got a provisional patent for it. The device is equipped with a force sensor with a range of force sensitivity between 0.2 to 20 Newton, and programmed to read and display force responses at different deflections, namely 0.2, 0.5 and 1 and 1.5 deflections every half a second. Changes in force response compared to a baseline were interpreted as mechanical deflection in the uterus. We performed preliminary studies in our rabbit fetal tracheal occlusion model, and uterine tone measurements were taken at baseline and after stimulation from the left and right uterine horns and at 26 days of gestation. The device was also tested on abdominal muscles for comparative measurements. Abdominal and uterine muscles responded to thermal injury differently with various intensity, correlating with the magnitude and duration of the stimulus. While no periodic abdominal contractions were detected, uterine contractions were recorded at 1.5 millimeter deflections every 5 seconds. That corresponds to 12 contractions per minute, and with a quick return to baseline after the thermal injury. We conclude that the Urotech device is more sensitive at deeper deflections, namely the 1.5 millimeter deflection, and can capture the sinusoidal nature of uterine contractions. We believe also Urotech device has the potential to provide objective data that will affect the practice and conduct of fetal surgery. With that, I'd like to acknowledge all the people in our lab and our collaborators from the bioengineering department and CEO Innovation and the veterinary services at the University of Colorado, Denver. Thank you.
Thank you. Ask a question. During the fetal procedures, probably two critical time points. One's when you open the open and get ready to open the uterus, and then during the case when the fluid's out, we're also assessing the tone of the uterus as well. Do you think that change in uterine volume, empty, full uterus, would affect measuring the tone?
I believe so.
Yeah. Okay, thank you.
Thanks. Next presentation: adherence to an outcomes of a university consortium gastroschisis pathway.
So, to improve and standardize care across the University of California medical centers, our fetal consortium developed a clinical pathway or guidelines. We sought to prospectively monitor adherence for uncomplicated gastroschisis and compare outcomes pre and post implementation of those guidelines. In addition, we compared outcomes and resource utilization for skin closure and fascial closure techniques in this post-implementation period. We observed excellent adherence to the pathway, with the majority of patients receiving closure within 3 days, avoiding paralysis with silo placement and reduction, having antibiotics and narcotics stopped within 48 hours of closure, and feeds initiated and advanced per protocol. Following implementation of the pathway, we observed a significant reduction in median silo days, ventilator and antibiotic days, days to initial feeds, and the percentage of patients receiving Broviax. However, there was no significant reduction in days to full feeds, central line days, and lengths of stay. While there are no differences between closure methods in age to feeds, central line days, or lengths of stay, patients undergoing skin closure had fewer days to closure and fewer days of ventilator, mechanical ventilation, and they were less likely to be intubated and more likely to undergo bedside closure without anesthesia and without an operating room team. So in conclusion, this study demonstrates the successful implementation of a standardized clinical pathway for uncomplicated gastroschisis, incorporating the principles of antibiotic and opioid stewardship. And despite less invasive support, more expeditious closure, earlier initiation of feeds, there was no difference in length of stay, suggesting that intestinal dysmotility intrinsic to gastroschisis remains a rate-limiting factor for hospital discharge. In order to reduce resource utilization, our consortium has updated the pathway to recommend bedside skin closure without intubation and without anesthesia when feasible, using sweeties for comfort and limiting opioids so as to minimize the risk of apnea.
Thank you.
Any questions? How easy was it to get all the different consortiums to agree on the pathway?
It was easier at some sites than others. Certainly at my own site, we had the habit of putting everybody in the silo, intubating, paralyzing everybody, and there was some resistance initially. But what was so helpful was knowing what other sites were doing and knowing that their outcomes were just as good. And once we realized we could do this with less resource utilization, less invasive, less stressful to the families, people caught on.
I think this would be great for the quality toolkit, if you guys wouldn't mind.
We'll be happy to add it. And I think the next step is to actually reduce the antibiotic use post-op. I'm not really sure that even 2 days is necessary, but we had to take it step by step.
What question?
Hi, not a question. Swaby from Jamaica. Love your consortium because it's something that we utilize back in our country because we don't have as many ventilators available sometimes. And so we go ahead and do minimally invasive procedures. Bedside procedures such as reduction and skin closure if necessary without anesthesia. So very good because it's utilized in the Caribbean as well.
Very nice, thanks.
I just can't help but resist saying that, we all think that we have so much to bring from our Western approaches to more developing countries, and there's so much to learn from the other way around as well.
Mm-hmm. Great. Thank you.
Next talk is umbilical access and laparoscopic surgery in infants less than 3 months of age, survey of APSA by Dr. Landman.
Thank you for the opportunity to present, and thank you for sticking around late. We have no disclosures. Laparoscopy is commonplace in all age groups within our specialty. The umbilicus of the young infant is unique, however, and complications related to umbilical access are unfortunately rarely reported, and we're really not sure how often they happen. So we hypothesize that they may occur more frequently than we know, and that there may be some correlations between the access type and or method and these complications. We surveyed APSA. We did a pilot study with our Riley Hospital surgeons. We came up with a short survey to try to minimize survey fatigue, and then got approval from the APSA Outcomes and Evidence-Based Practice Committee as well as the IRB. This was REDCap based. It was anonymous. It was there were 3 reminder emails we're all used to getting. There are demographics on screen right. 62% of our surgeons did 21 or greater laparoscopic procedures annually, and you'll see the case breakdown just below that. We had a 31.3% response rate, and importantly, the question, have you experienced any direct complication of trocar placement? 10% of surgeons responded yes. And below that, you'll see some of the complications that were described. Importantly, 5.5% of these surgeon respondents had an air embolus, and there were 3 surgeons who had experienced a death as a direct result of umbilical access. In patients who had an umbilical cord stump still in place, we didn't find any association between a complication and where the abdomen was entered or how it was entered. And in patients with no umbilical cord stump remaining, there was a possible association between any complication and where the abdomen was entered, but none on how it was entered. So in conclusion, 10% of surgeons reported complications of umbilical access, including life-threatening events. Essentially all methods had a complication reported. And importantly, and I think the main purpose of the study is surgeons should be aware of these risks and be prepared to manage them emergently if they should arise. Thank you. I'll take any questions.
I have a comment actually. So I think the study is great, mostly to just make us aware that these things happen, because I cannot think of a better access though. So I think it's going to still be developed.
That's true, yeah. We certainly wouldn't advocate against it. I think it's more of just a knowledge that it could happen. For instance, within the survey, 15% of the respondents didn't know that air embolus or CO2 embolus was a possibility. And so I think just awareness is the big thing.
Thanks. Great job.
Rusty Jennings, and critic of all the comments just said, I would say that any time we do a procedure that has a 10% complication rate, and I forget, 0.5% mortality from air embolism, is an unacceptable procedure. We as a group need to admit that we're not doing it well, that we're harming children by doing this very easy access point, then we need to do something better, either change the technique or we need to come up with a better access site. But I would advocate for the children, not for the access site.
I think importantly, and I thank you for that comment, Dr. Jennings, is that the 10% of the people who responded, and this likely represents thousands and thousands of laparoscopic surgeries. So the rate, which we couldn't figure out from this methodology of injury, is probably exceedingly still very low.
Of course. Yeah.
Thank you.
Thanks.
Last presentation, surgical management of acute aortoiliac thrombosis in a neonate.
Sound's not on. In a neonate. Our patient is a 90-year-old girl who presented to an outside hospital with fussiness, feeding intolerance, and anuria for 1 day. Her birth history is unremarkable, and she went home with her parents and never required IV or umbilical access. At presentation, she was tachycardic and hypertensive. Notable exam findings included cool, pale lower extremities with mottling. Femoral pulses and pedal Doppler signals were absent bilaterally, with sluggish capillary refill at the toes. Labs were notable for BUN and creatinine elevation. Her lactate was within normal limits. An echocardiogram revealed normal cardiac and heart anatomy. Duplex abdominal ultrasound showed a large occlusive aortic thrombus extending from the SMA takeoff to the bilateral common femoral arteries. The patient was started on IV heparin and, in consultation with hematology, was not deemed a candidate for systemic thrombolysis due to concerns about bleeding. A peritoneal dialysis catheter was placed urgently and dialysis was initiated. After 10 days without improvement, she was transferred to our institution for consideration of surgical intervention. CT angiogram was performed, which redemonstrated the extensive thrombus within the abdominal aorta from the SMA to the common femoral arteries, with reconstitution of flow at the superficial femoral arteries bilaterally. Despite no evidence of flow in the renal arteries, there appeared to be some degree of preserved perfusion to the kidneys via lumbar collaterals. Given this, we believe that there was a chance for some renal recovery if antegrade aortic flow could be restored. The patient was taken to the operating room the following day for open aortic and bilateral iliac thrombectomies. After a midline laparotomy was performed, the small bowel was retracted cephalad and the retroperitoneum was opened. The aorta was exposed from the level of the left renal vein to the bifurcation, and proximal and distal vascular control was obtained. A transverse aortotomy was made proximal to the IMA takeoff so that we could effectively thrombectomize the IMA. Thrombectomy of the distal aorta was performed using serial passes of a Fogarty balloon and manual pressure over the vessel to evacuate thrombus from the artery. The IMA was cleared in a similar manner. The left common iliac artery was cleared using serial passes of the Fogarty balloon until adequate back bleeding was achieved. The right common iliac artery was cleared in a similar manner. Brisk back bleeding confirmed vessel patency. The proximal aorta was then cleared by removing all visible thrombus, followed by serial passes of a Fogarty balloon. Of note, the renal arteries were examined and noted to have pulsatile flow after thrombectomy of the proximal aorta, so additional manipulation was not performed due to the small size of the renal vessels and risk for injury. Once all thrombus had been removed, the aortotomy was closed, primarily using a running 7/0 proline suture.
All right, thank you. We wrap it up.
You can stop the video.
Thank you, everyone.